you so much for Dr. Nurul for the very practical, concise and sweet talk just now. So here comes almost the end of our talk. However, I think I've seen some questions in our chat box. In interest of time, I have picked only a couple of questions to be answered because of no time. So maybe I'll go with Dr. Nurul first. I think there's one question asking about, is there any role of MDI for post-OP patients who completed steroid treatment but still symptomatic?
Okay, yeah. Hi, thanks. So basically, I do give patients MDI. Patients came in with persistent cough that lasted about 2 months, 3 months, 4 months. So I give MDI budesonide 400 microgram BD. So there's one study to give up to 800 microgram BD. So yes, I do give. It's mainly for the hyperactive airway due to a Covid19 infection.
Okay. Then they asked me to do swab and all, then the result hasn't come back, so they didn't allow me to come.
Sorry. KKCR, can you please mute your mic, please?
Okay. Then later I'll meet.
All right, sorry.
Please unmute yourself, Lee.
Yeah, okay. So, yeah, thank you so much, Dr. Nurul, for your opinion on the MDI post-OP. So I think we can have another questions that I picked maybe for Dr. Koh, since you presented on post-COVID data. So I think two questions asked almost the same question. The two people asked the same questions is about so-called delayed OP. So both of them have experienced seeing patients coming back after a month of discharge and after completed steroid. When they did some scan, they show some persistent GGO. So what is your opinion on that? Would that be any treatment? I think you have presented partially as well from our data. Is there any treatment required? And do they get better with the steroid and things like that?
Yeah, again, so I think it would depends when do you scan the patient. So in literature, they scan at 4 months, 6 months, and things like that. So our data scan about 4 months. So we do see some residual changes. Again, we show that the imaging changes did not correlate well with what patient symptoms and things like that. But again, we do not have correlation to lung function or any other inflammatory markers. So I think basically at this stage, we are still very clinical based. So if patients have no symptoms, despite the imaging is very bad, we will not jump straight into treatment. We will do more further workup. We might repeat scan. We might do lung function testing. We might do other tests, and then we will decide from there. Yeah.
All right. Yeah. Totally agree with that. Yeah.
There's one question from Eric Daniel from Jakarta. Dr. Eric.
Yeah, Assalamualaikum, Dr. Jamal. How are you?
Go ahead.
Hi. Again,
so we have to entertain your question.
Hi, Eric.
Hi, Ko. How are you? Always impressive as usual.
Go ahead.
Yeah, thank you. So again, thank you very much for Dr. Jamal for inviting us. I saw earlier that Sefa actually joined us and a few of my fellows. So again, a very nice talk. Congratulations to both speakers. So I have a very and this is a very tricky questions to answer, I guess, since a lot of debate circling around this question. So the questions will be about organizing pneumonia and what's the relations to the pulmonary fibrosis. So the question is, either you, Ko, or Nurul, could you guys pinpoint or what are the predictors actually for patient who gets an organizing pneumonia and later on develop a pulmonary fibrosis? Is it just really whether the patient got traction bronchiectasis on a CT scan or any other CT appearances that we might take it as a predictors for pulmonary fibrosis? Second, in Indonesia, we are actually not every hospital use nintedanib or pirfenidone for patients with organizing pneumonia. to actually slowing down the progression for pulmonary fibrosis. Can you share your experience on that, or Dr. Nurul? Thank you.
Dr. Nurul?
Nurul?
Hi, Eric.
Hi, how are you?
Hello, hi, fine. So with regard to your question, we did not use nintedanib, any antifibrotic, nintedanib or pirfenidone for our COVID patients. And it depends, like what you say, the traction bronchiectasis, it could be one of the features in the OP pattern when you do a CT scan. It depends at what time did you perform the scan. At what time did you request and perform the scan? Basically, at what stage where the patient was at that time. So basically, as you can see, due to the pathological process, it started at the airways, and it started at the airways, it started at the peripheral, and then moved to the center. So this, besides even the airway involvement, the bronchiectasis, as well as the vessels angiopathy, usually it will reverse. It is a reversible process. That's what we usually saw in our patients, the serial HRCT in our patients. Yes. And the number 2, what was it just now?
About the antifibrotic.
Oh, antifibrotic, I did not use any antifibrotic in our COVID-19 patients as yet.
Okay.
Yeah.
Maybe I can just add on it, because
yes, please.
I think when we see the patient during follow-up, if we see, I think what the question is there any specific fibrotic pattern that is specific to COVID-19 related OP? Right. So I don't think there is, because from my experience, when we see the patient in clinic, when the patient survive and come to us, there might be a lot of post-ARDS changes. There might be a lot of post-infective changes, which those condition itself can lead to some fibrotic changes on CT scan. But again, it will give us more specific distribution, like those non-dependent area, the anterior aspect in the ARDS, post-ARDS changes and things like that. I'm really not too sure whether usage of antifibrotic will be useful in organizing pneumonia in COVID-related OP, because my belief is that if the driver of that OP has already been switched off, the disease itself might not progress. What the patient will get, of course, is some footprint of what he had previously, COVID-19, that might be some linear scarring, linear band opacity and things like that, which might not progress. But again, only time can tell. And whether it leads to any physiological impairment, I think that will be interesting to look at in the future. Yeah.
All right. Dr. John, if I can have one follow-up question for Ko, actually. So I don't know if you already have a look on one of the video posted on YouTube, which is Peter George from Brompton. So he discussed with one of the doctors from India about pulmonary fibrosis post-COVID. So the question is whether we should schedule a patient for a reassessment. I mean, let's say for severe or critical ill patients, we can schedule the follow-up and the CT scan in 3 weeks after we discharge the patient. And we also see actually in few case reports that the CT scan appearance actually changed after a few months, let's say 6 months. So what is actually the best time for us to bring back the patient and do a systematic approach for the reassessment? Yeah. Can you hear me, Ko?
Yeah.
Yeah.
I think the post-COVID follow-up algorithm published in BTS, it's mainly best what the resources have in UK. As you know, a few steps away in UK, there's a hospital. You can go to a clinic, but I think it's very different in our region.
Correct.
The access to healthcare, the access to scan might not be as easy as in the UK. So of course, I think they follow at 4 to 6 weeks. They can do lung function in a very close interval and scan like that. For us, I think what we need to do is we have our data that we scan at 4 to 6 months, and then we know what's the outcome. So actually, for now, we don't scan them anymore. We try to do X-ray because based on what we have understand from our group of patients. So I don't think I can give you an answer when is the optimum time, but from our experience, I think 4 to 6 months we will reassess. Then if needed, we will follow them up again and see what we can do for them. But definitely, of course, if we have the resources, we have the access to healthcare, 4 to 6 weeks like the UK would be the best, but I don't think we can do that.
Yeah, I agree. It's actually for more on the, as part of, for the data collection, so that you can have insight in the future, what we're supposed to do for this post-COVID patients. But if, let's say, in clinical practice, we do CT scan for everyone, and they have some residual changes, be it like at 4 months or at 6 months, but they improve clinically very well. They have no symptoms with even a normal lung function. What should we do? We can't just follow up the pattern, the residual pattern on the imaging. So to be honest, it's not practical to do in our local setting. Yeah.
All right. All right, excellent. Thank you very much, both. Thank you. And congratulations again, Dr. Jamalul, Dr. Nurul, and co. Very impressive. Thank you. Cheers.
Right.
Yeah, cheers.
Thank you, everyone. Thank you to the excellent speakers and the participants. Thank you for the very excellent interactions. So I think we have to call it a day since it's really way past 9 o'clock in the morning already. Everyone has to get back to their clinical work. And I believe we all agree that we're all still learning about COVID, and it's still, there's lots of new data coming out. So we hope we can contribute more data to the world. And any questions? I'm sorry that I can't pick up your questions in the chat box. I can see some people are still asking questions. Do not hesitate to actually email us. I think Dr. Jamal has shared the link for email address. Then we can forward the questions to the speakers and we can get back to you as soon as we can. Thank you so much and have a good day. Bye.
Thank you, Lee.
Thank you, everybody. Eric.
Thank you very much, Dr. Jamalul. Thank you. Impressive. Very, very good. Thank you, Ko. Thank you, Nurul. Thank you, everyone. Take care.